A 55-year-old female patient, Mrs. Pule, comes to the emergency department. She is a known patient with deep vein thrombosis and also osteoarthritis on treatment for both. She comes in complaining of nausea, and she says sometimes she's got dizziness and fatigue. In addition to that, she also complains of intermittent epigastric discomfort, and at times it becomes an excruciating pain. We took her into the unit, but just before we knew it, she vomited fresh red blood on the floor. And now, this was not a pleasant sight, especially to the family. And the question is, what could be the possible causes for this symptom? Hi, you are watching ED Files, and I am Dr. Thabo Mafa. Vomiting of blood or hematemesis is one of the symptoms a patient may experience when they have upper gastrointestinal bleeding, or in simple terms, upper GIT bleeding. And what is it? This is bleeding that occurs proximal to the ligament of Treitz. And this is a suspensory ligament at the junction between the first part of your intestine and the second part. And that would be between the duodenum and the jejunum. The main function of this ligament is to make sure that there is enough support between these two parts of the intestines so that they do not kink and eventually result in bowel obstruction. We have spoken about hematemesis, which is vomiting of blood. And this is one of the symptoms you could see in a patient with upper GIT bleeding. But there are other symptoms as well a patient may experience. And some of those are Melina stools. These are dark, tarry stools a patient would experience if the bleeding is from the upper GI tract. Secondly, a patient may also present with hematochezia, which is passing of bright red blood from the rectum. However, this condition is very rare in upper GIT bleeding. Other symptoms could be dizziness. The patient could be pale. There could be syncope or fainting. They could also present with body weakness and also a fast heart rate, which we call tachycardia. Upon further inquiry with Mrs. Pule, she mentions that she was diagnosed with osteoarthritis, and that was about 12 months ago, and she's taking treatment for it. She is taking non-steroidal anti-inflammatories at a higher dose and 3 times a day. She was also diagnosed with deep vein thrombosis about 3 months ago. She is on what we call an anticoagulant. In this case, she's taking warfarin, 2 tablets a day. The causes of upper GIT bleeding can be classified into 2. We've got variceal and non-variceal. What do we mean variceal? These are veins which are engorged with blood, with high pressures in them, and they are at risk of bursting and bleeding. And in most cases, these are small veins. Number 1 would be portal hypertension. If there is high pressures in the portal veins, that would eventually bleed as a result of the high pressures that we mentioned. There's also liver cirrhosis, especially for patients who take excessive amounts of alcohol in some cases, or chronic liver disease, can cause damage to the liver tissue and it goes into cirrhosis. That in a way will result in high pressures within the portal system. And thirdly, you can have thrombosis of the portal vein, resulting in the same mechanism of high pressures and formation of those veins that we mentioned that can easily burst and bleed. On the non-variceal causes, you could have conditions like peptic ulcer disease, which is ulcer of the stomach or the intestine. You could also have cancers. And in some cases, you find a patient who's been taking medication for some time, especially the non-steroidal anti-inflammatories or anticoagulants. You could also have a patient who's got an infection like cytomegalovirus or Helicobacter pylori. The other causes of non-variceal bleed, upper GIT bleed, you could have a patient who induces vomiting, or a patient who is vomiting excessively, ending up with bleeding of the upper GIT tract. And this we call Mallory-Weiss syndrome. This happens because as a patient keeps on vomiting or inducing vomiting, they can easily tear the esophagus, and that can be deadly as a result of excessive bleeding you could have from that. In other cases, you could have a patient who accidentally swallows a sharp object like a piece of glass. That can easily cause upper GIT bleeding. Now, what are the risk factors that Mrs. Pule is having in this case? What put her at risk of having this condition? There are two things that I could mention. She is a patient with osteoarthritis who is on a high dose of non-steroidal anti-inflammatories. Secondly, she has been diagnosed with deep vein thrombosis and she is on a blood thinner. Those two conditions did put her at a very high risk of having bleed within the upper GI tract. So when I examined Mrs. Pule, these were the findings. She looked very pale and she was having lethargy, meaning that she looked very tired as well. Her blood pressure was very low. It was about 90/50. She had a fast heart rate of 120 beats per minute. Otherwise, all other vitals were within normal limits. We examined her cardiovascular system. There was nothing of note which was abnormal. Her chest was fine, but the abdomen, she had severe epigastric tenderness. And also, on the investigations that we've done, we found that on her full blood count, her HB was low. It was 5.2. In her case, a patient within the age that she is in, she's supposed to range from about 12 to 13, her HB. Secondly, on the kidney function test, there was an element of renal dysfunction, and most likely due to the non-steroidal anti-inflammatories that she's been taking. And we've also done INR, which is a measure of clotting that is standardized. Her INR was 7, which was very high. An INR of a patient who is on treatment for deep vein thrombosis is supposed to be between 2 and 3. However, in her case, the INR was higher. And now, what about treatment? How do you treat a patient in this condition? Remember, her blood pressure is very low from the excessive bleeding that she has already had. We had to give her intravenous fluids to boost her blood pressures. However, we had to do it carefully so that we do not further dilute her blood with the fluids that we are giving. Secondly, we had to give her an antacid, a high dose of that, intravenously. We also gave her tranexamic acid to help her not to bleed further. And in view of the INR that was quite elevated, we gave her vitamin K to help her to clot much better. And last but not least, with regards to treatment, we had to give her emergency blood. And as we did that, we also ordered some fresh frozen plasma to help with the clotting process. Mrs. Pule was managed and stabilized in the emergency unit. And soon after that, the general surgeons came and took her for theater, where they've done further investigations on her to see what's causing the bleed. They did a gastroscopy to see exactly what's causing all these hematomas. In her case, she had a bleeding gastric ulcer. They managed to control and eventually stop the bleeding. She was taken to ICU where she made recovery as they continued to transfuse her with blood. So in conclusion, upper GIT bleeding holds a very high mortality rate if it goes untreated. So, early recognition of the signs and symptoms and commencement of treatment as soon as possible can save a patient's life. And thank you for watching.